Sincerely hope that this is a safe space and that what happens at the dental festival stays at the dental festival, or what's said at the dental festival stays at the dental festival. Because I have a confession. I am a terrible dental hygienist in that I don't practice what I preach. I certainly don't brush after every meal. In fact, I average about once a day, and I hate flossing. If I'm flossing, it is most likely a very special occasion, like the coming of millennium. However, this is not the most uncomfortable place that I've shared this information. In fact, my OBGYN has delighted in knowing this, and she's used it against me twice successfully. I'm a mother of 4, and after every time I've given birth, there's always been some type of complication. So they're ready for me when I come. So the room gets sort of anxious, and I'm building up with a lot of fear after my last birth, and my OB takes a room full of nurses, doctors, and anesthesiologists running in, and she calmly and coolly collects them all, announcing, "Don't worry, guys, relax, we have this under control. She doesn't floss, and that's why we can't get the bleeding to stop." What a diagnosis, right? But as embarrassing as that was, and alternatively soothing, I was very proud of her in that moment, because at that time, she took something that she sees so commonly and has seen in me before and looked at it differently. And that's what I hope to encourage all of you to do by the time I'm off this stage. Because while my oral health is, yes, deplorable, okay, I am not the patient that will sit in your chair with pocketing, bleeding, inflamed gingiva, and I certainly don't have any bone loss. No signs of periodontal disease, okay? What I do have is exceptional oral function, nice broad dental arches that fit all 32 teeth, beautiful, and I absolutely positively have what I like to remind my husband of every day, perfect occlusion, okay? And you'd be surprised to know that actually, according to research, I am not the exception, I'm the rule. Yes, it turns out that oral function has always had a bidirectional relationship with periodontal health. So, when you're seeing all of those patients that come in and they have parafunctional habits, they have poor lingual function, and they're struggling with traumatic occlusion, you'll commonly find, and research has shown, that that does impact, that biomechanical distress will widen the periodontal ligament space. It's going to increase marginal inflammation, and it's going to cause bony defects vertically. So what we're seeing in the mouth and we're addressing, we're hyper-focused on as biochemistry, bioinfectious components. But there's so much more we're not seeing. The mouth is crying out because our mouths are not much different from a toddler kicking and screaming, throwing a tantrum, Britney Spears getting out a window with an umbrella, a Kardashian butt naked on social media, or a middle-aged man driving a very flashy sports car. And I'm sorry for that last one. But it's all attention-seeking behavior. The mouth is crying out for something we've known about for over 100 years. This is not new. Edward Engel and one of his most prominent students, Alfred Rogers, in the early 1900s, did extensive research and papers on the impact soft tissue pressures have on craniofacial development and oral function. So when we have suboptimal oral function, it's going to impact in many ways, but we will see it reflected incredibly in the periodontium. So, what did we do with this information that we knew for over 100 years? Well, of course, we just threw it to the wayside. And in other places, other countries like Brazil and Australia, they picked it up. So they've got wonderful standardization, they've got postgraduate education, and extensive quality research on oral function as a specialty. And you'll be surprised to know that while we, first world America, have 70% prevalence of periodontal disease, Brazil and Australia are at 40 and 23% respectively. What are they doing that we're missing as a field, that we cannot provide our patients adequate stability? I want to challenge you to take all the Kareses in your chairs who have all the knowledge and information as to why they should brush and floss, but you know they're not going to brush and floss, and provide them with an alternative way to get stability, because they deserve the right to optimal oral health, just like the citizens of Brazil and Australia. So I want to give you 5 things that you can look for in your dental chair, in your patients, and I am going to do that through a little spoken word using the acronym START. Every new day begins an awakening, a chance to review systems and ideals taken in. Though mundane and undervalued, new opportunity risen. You have to start. You know their faces and stories, their excuses and flaws. Today is the day for a clinical overhaul. You have to start. The signs have always existed. Periodontium's cries have persisted. With pocketing, gagging, and deconstructed dentition, you have to start. Strong gag reflex taken into account. It needs referral to empower surmount. Start with this S that causes more than poor x-rays. You have to start. Transverse deficiency, a common sign. Narrow arches and perio commonly combine. Second letter, but first T. You have to start. Audible breathing should never occur. Hearing them breathe requires rapid refer. An A in the way of stability for sure. You have to start. Respiratory disorders are a red flag for asthma, sleep apnea, and respiratory lag. This R serves as your catch-all. You have to start. Tethered oral tissues require more than a snip. Take a good look at the tongue, buccal, and lip. This second T is about function and not a fad. You have to start. The signs have always existed. Periodontium's cries have persisted. You will start. Stories of stability, you are now a part. Profound clinicians, I know you'll start. Thank you.